Good morning, everyone. You've heard all of the introductions and paid political announcements. This morning's presentation will be by Dr. William Rick, as everyone knows him, Jackomis. Dr. Jackomis has been a presenter to PSN before, and we've asked him to come back this year to give us an update on maintaining and promoting oral health with Parkinson's disease. Dr. Jackomis has been in practice for more than 20 years. He calls himself an aesthetic dentist, but in reality, he does a lot more than that. There are a number of us in the PSN who are familiar with him, having been patients for years. And his talk today is going to provide us with insight that is appropriate to both patients, people with Parkinson's, and their caregivers.
Well, thank you all very much for having me to talk today. We did this a couple of years ago, and this is an updated review, some of which is repetitive from what we talked about before, and I'm going to kind of tell you where things are moving. The world is actually moving in dentistry. So there's a few topics, and we'll kind of build up into what's happening. So today, I've called this Time, Tremors, and Teeth, an updated review of dental health with progression of age and Parkinson's. David, if you can go to the next slide for me. Whoops, can you go back one?
Oh, did
who I am.
Oh, sorry.
No, there I am. This is who I am. I am a practicing general dentist. I've got an active practice 4 days a week, clinical. I'm a fellow of the Academy of General Dentistry. I've got more than enough hours for my mastership in the AGD. As my practice has aged, I have refined my focus on my office with an aging population. So we do have a lot of seniors. And one of the foundations of the practice is bringing advanced technology into the practice as a basis for delivering care. Over the years, I've become I don't just run my practice, I also teach advanced technologies. I've spoken for multiple companies and associations and study clubs. I do a lot of advanced technology stuff with lasers and with implant technologies. And hopefully, possibly by the next time we talk, we'll also be doing materials lectures for several corporations. I'm in a bunch of professional associations, study clubs, most of which is the clubs tend to be pretty local. The associations are national. One of my other side adventures is litigation support. So I serve as an expert witness in cases of malpractice and for Board of Dentistry concerns where someone's being brought in front of the Board of Dentistry. I do represent both sides, and I give an honest opinion because that opinion can't be bought. Just my time. And David, next slide, if you would. My agenda today is to kind of review the 3 types of aging that happens to everybody, and then some of the unique issues that arise with Parkinson's disease that complicate oral health. Hold 1 second, if you will. Not sure if you guys hear, I heard a radio. I think it's on my side here. Anyway, and what the fallout is when oral health starts to break down. So and then the $1 million question, how do you manage it to prevent failing dental health and oral health? And what's on the horizon? What's kind of coming for today and tomorrow? What can we do? And what's the best way to manage people particularly with Parkinson's? But as you have that failing oral health issue with the progression of disease. Next slide. The biggest concerns right now are aging. And there are 3 types of aging that we really see. And the first type of aging that we see is the medical aging. A patient gets older. And that is as life progresses, life systems break down. The management that we encounter in this country tends to be focused on maintaining and improving life quality. You also have, as we kind of go from a general to specific, you start to see the aging of oral tissues. And oral tissues, my focus here, we start to see that happen as well. Teeth wear out, bones break down, gingival tissues, gums breakdown. You see recession, you see cavities, you see chips, wear, erosion. The third aging to focus on is not just that, but also the materials, the equipment that we use to deliver restorative and rehabilitation of the teeth. Those are not permanent either. So every time we put an artificial product in your mouth, that is a material and a product that's subject to fatigue and insult. The most materials that we see now, we see metals. We all grew up with amalgam, which was a big one. Not used as much anymore. We've kind of progressed into composite resins and ceramics. We've also got probably the only real metal used nowadays is titanium, and that's really the implant world. And we're going to kind of come over on that. Next slide. So as a patient is aging, what happens? Medical health breaks down, and it happens as a natural process. Oral health follows the breakdown of medical health. You'll also see oral health, and there's a really close correlation between oral health and medical health as well. So if you can maintain good oral health, you tend to find medical health maintained. Vice versa, as they work hand in hand together. The data on that is becoming very clear. I have an interesting book that was written in the 1930s by a pathologist out of the University of Pennsylvania. And in the front of the book, he calls the mouth the gateway to the body. And it's a way to indicate what's happening in the body if you can see changes in the mouth. Well, there are natural changes that occur over time. One of us changes to saliva, dry mouth issues, and then we also start to see with time delayed healing, the recovery from restorative processes. So we have to be cognizant of that as we're doing any treatment modality at all. With aging, we also see an increased use in medications. In this country in particular, more so than a lot of others, we have an enormous use of medications, and we see the industry of pharmacology right now is very strong. The pharmaceutical industry is a powerful lobby, and they really want to dominate, even though there sometimes is alternative therapies that might be an adjunct. The one pushback where we're seeing the pharmaceutical industry not succeed right now is really in pain management. We're seeing some better modalities with non-narcotics, but it's taken a lot to get down that path. There are limited alternative therapies. The limited therapies that we do see, you see them coming out from other countries, both in the world of medications and in different treatments. But in this country, it is very limited. With the heavy pharmaceutical use that we're seeing, we see patients will come in with a shopping list of medicines, and it becomes interesting to try to manage the side effects of some of these meds. So one of the biggest negative impacts is called medication-induced xerostomia, or dry mouth, and you'll see it there as mix. That dry mouth can be catastrophic. And the problem with it, we have a lot of limitations to treatment. The other thing we run into with medical aging is we'll see mechanical dexterity degrade. People can't brush as well as they did. They can't floss. They can't hold the toothbrush. They can't get the floss between the teeth. They can't manipulate water picks. And that's really where Parkinson's comes into play, because it accelerates any breakdown, because the medical response to aging is accelerated. And I think that's probably the biggest negative impact with Parkinson's. Next slide, please. As we go to kind of a lower level of aging here, we're looking at the oral tissue, and we have three principal oral tissues that are involved. That's teeth, bone, and gums. Pretty basic. When you see gum recession, that's really a loss of bone, and so the bone actually recedes. Gums follow the bone. Now, in the classic model, we see bone recession occurring sometimes from periodontal impacts and from social habits. It's the typical smokers, the smokeless tobacco users, and we'll see a lot of bone loss. Also, people who don't get regular care. we'll see buildup across the teeth, allows a little bit of bone death, and the bone recedes. And then the gums follow the line and the contour of the bone. So when you see the gum line down with recession, the bone has already dropped away. And then you can develop that into a periodontal condition where you've got actual periodontal disease and recession. And you probably heard the old adage where someone can be long in the tooth. Well, that's where that term comes from. That's a periodontal degradation where the teeth actually appear to be longer than they really are, because you're not just looking at the clinical crown, you're looking at the clinical crown plus a lot of the root surface where the bone has dropped down. As the bone drops down, teeth loosen, the exposed root surfaces are not as strong as the enamel. The dentin is exposed. That exposure is really susceptible to decay, and that results in tooth loss when you get down beyond the necks of these teeth. The exposed root surfaces, because they're not as hard as that enamel surface, anything that sits on there, like food products, decay, highly acidic products, anything that's not cleaned away timely, that's where you're going to get the source for the decay, the food source for the bacteria. Parkinson's, because you're breaking down the ability to keep that clean, that accelerates that natural aging, and you get increased risk of decay and oral tissue failure. And it all has to do with mechanically and also the mechanical degradation, because you don't have the dexterity, and it's also because of the medications that are out there that are drying you out. Dry teeth, dry mouth accelerates decay. Next slide, David. We also have materials. Materials wear out. Everything that we do that's not you is something that fatigues and wears out. It doesn't matter what the material is. Right now, we see materials for our restorations. Historically, we've had a lot of metals, which is amalgam, the old silver mercury fillings that we used. One of the things that they do is they'll break teeth. Even though they're designed not to expand and contract because it's a metal, it's basic physics, they will expand and contract and they'll crack teeth. Ceramics, much more modern product line right now. Historically not as strong, but the newer products are getting stronger, and the bonding sources becomes better and better as well. It's a lot of chemistry, very fancy chemistry, and that's kind of where the future lies on the material science. But once you put something in there, everything attacks these margins where the artificial material meets tooth structure. A metal will corrode, and that's how those old silver mercury fillings actually sealed the tooth up. It's a rust product. Now, we don't like to say it's rust, but it is a corrosion product that provides a seal. Ceramics crack and they can fatigue, and they require certain amounts of thickness for their strength. And bonded resins wear out because they're not as strong as the ceramics, and they can leak across any large bonded margins. So all this happens the minute it's placed. Every time you eat a meal, every time you eat peanuts or whatever, hard products, soft products, acidic products, every one of those margins where the artificial material meets the tooth structure becomes the area of attack. So the better we can seal those areas off and have a proper product that can handle the bite forces and the function that they're under, the better that the material will survive. And that's the marginal interface. That's where the bacteria can get in, and that's where you'll see recurrent decay. Again, because Parkinson's has an issue with mechanical management and medical management with all the medications, you're more susceptible to materials failure because we can't seal. Again, that's where Parkinson's really comes into play as something that has to be managed a little closer. Next slide. Oh, next slide, David. So how do we manage? Okay, well, patient aging is a natural life process, and we have to rely on the physicians. This is really their world. We've got traditional medical models that exist in this country, or the physicians are taking care of it. You're starting to see an expansion of alternative therapies for almost everything, particularly as things are proven not to work, alternative therapies come into play. That's really the world of medicine and physicians, not so much with dental, with what I'm referencing there. But oral tissues, we tend to have three different models for management. This part applies to everybody. You have a mechanical model, and that's where you reduce the bacterial load. That's where you brush, you floss, you water pick. And that whole process is to remove bacteria plus the food supply for the bacteria so they don't sit. So to get decay on any tooth, you have to have the bacteria, you have to have a food source for the bacteria, and you have to have time. So in the mechanical model, everything we do is based on disrupting one of those three components. And that's that is the traditional model in dentistry. Now, we do have a limited medical model as well, particularly in areas where there's limited saliva. And that's where we can get into medications to help. And the medications are really focused on helping with saliva and salivary flow. And they're designed to buffer any acids that are sitting on the teeth that promote demineralization. Now, every time we eat, doesn't matter what we're eating, we generate acids naturally in our mouth and we start digestion. Those acids can promote bacteria to grow and to thrive, particularly when they have a food source. So if we eat and don't give our natural saliva time to buffer the acid, what happens is we get demineralization and decay. And so one of the focuses with a medical model is to use different medications that will get our saliva to produce a higher level of flow. The problem with that, it's not going to change the quality of the saliva. So if we have a low mineralized saliva, that's not going to help us as much. Some saliva is better than no saliva, but it's still not a complete solution. So the other thing that we'll do as a third component with aging oral tissues, and you hear this a lot with children, and I think it's really critical in an aging population, is to add supplemental fluoride to our regimen. There's kind of two ways to do this. Supplemental fluorides are topically applied, and what happens with fluoride, there's a lot of misinformation on the internet about this. Some people say there's neurotoxicity. Some people will say there's a lot of data out there, a lot of missed data. But this is about the most heavily researched product in medicine. Very safe, it's dose dependent. But what the fluoride does is it gets into the crystals of the enamel, and it knocks out one particular phosphate ion, and it allows the fluoride will go replace it in the surface of the tooth, in the different parts of the tooth, both the dentin and in the enamel. What that does, it reduces the ability of that tooth structure to be demineralized. And that's how it works. You'll hear the term hardening the tooth. So fluoride becomes very important as a supplement. Normally, we'll supplement fluoride topically with varnishes. We'll also do it with home rinses. One of my favorite products over the counter is Act Fluoride, which I encourage every senior to be involved with. And then it's something that you'll swish and spit and then not rinse out. Problem is do we have dexterity to spit and to swish it without swallowing it? Next slide, please. In the patients with Parkinson's, mechanically, because we have a loss of dexterity, sometimes I have found that the grip on a toothbrush can be very difficult. Can't curl the fingers quite as much. So duct tape is a magic thing, and this is one of the best ways to use duct tape. Wrap a whole bunch of duct tape around the toothbrush for the Parkinson's patient. That increases the diameter so they can get a good grip on the toothbrush. I prefer electric toothbrushes. My favorite is the Oral-B series with a round head that reciprocates. Enormous amounts of clinical data have come out on that to support its use. We also, of course, floss plackers. The soft picks are a gum product, which are fantastic. They come in two sizes, large and small, and they're great for getting in between the teeth when you can't. Stimident wedges is kind of an older thing. It's a little soft wood wedge that some people just love to stick between the teeth. It's great for removing physical debris. Those are all mechanical tricks for patients with Parkinson's. The hardest thing is you really are relying on increased use of caregivers. Sometimes, as I've seen, as my patient population has aged, the patient population right now, where we're relying on home health and also in facility caregivers, sometimes they just don't do it. They're not really good about it. And then one of the other issues that we do in my office, we try to increase their frequency of coming into the office where we can get on top of it. In our office, we will almost always apply some level of fluoride to someone who we think's at risk, and we'll also add, try to get it to be added in their home regimen with the caregivers. So in some severe cases, we see some people aren't even getting their teeth brushed every day. Very complicated thing for some of the caregivers, and trying to get into the facilities to train them can be very difficult as well. Next slide, David. So again, a little bit of what I've talked about with Parkinson's patients, we want to make sure we're maintaining the medical side of things and watching through the medication so that we can improve saliva and flow. The systemic meds for this are not really good. They're not really terribly successful. There's a couple of them out there that are used, but it's something I wouldn't rely on. There's a lot of over-the-counter products and prescription products that are lozenges and rinses. Again, limited products. One of the oral lozenges is Mislex. It's really used to treat fungus and yeast infections that come up with patients. A lot of these patients are really people wearing dentures or partial dentures, and they can't remove them and take them out and clean them properly. So we see a lot of those yeast infections. The lozenges I'm referencing there are really of limited use. There's a couple of rinses. One is called Paradex, and it's chlorhexidine. There's a couple different names for it. It's a prescription rinse, and it is used widely. I think it's not used really well. Its biggest drawback is it has a big staining component. It's used by periodontists in the periodontal world to manage bleeding gums and bleeding gum tissue. And I challenge that a little bit, because if you read their material safety data sheet, it tells you it's not effective in the presence of blood products. So I always wonder why we use it. But one of the side effects, or not side effects, one of the side uses for it is to use it for decay control. The biggest thing with it, it leaves a scaling discoloration on the necks of the teeth that a lot of people push back on and resist. There's a newer product that's over the counter. It's called Closis. It is an excellent product. It comes in 2 flavors, unflavored and mint. It's an over-the-counter product you have to ask at the pharmacy counter for. Fantastic product, great for gum health. I don't know about its ability to reduce decay yet. It's too new of a product, but we've been using it in my office for 3 or 4 years with excellent success. If you do want to try it, I would recommend using the mint flavor. The mint flavor is much more pleasant than the unflavored. Another relatively new product I've come across in the past 2 years, 2.5 years, is a dry mouth lozenge called by ACT, which is a Johnson & Johnson product. They are a fantastic product that I love for anybody with dry mouth. They have a mild lemon flavor, and the mild flavor that's located in this is it doesn't burn. It doesn't create any negative sensation. I discovered this going through radiation and biologic therapy for a family member, and cancer treatment, and it was absolutely a lifesaver for no pun intended there. But it was a fantastic product for managing oral discomfort with dry mouth, and it is very soothing, and it's also anti-cariogenic, so it doesn't promote decay. The other product line that I'm really impressed with is a series of xylitol-based products from a company called Xlear, and you'll see it on the slide there, xlear.com. They have a whole product line dedicated to management of oral tissues. And the focus was xylitol. Xylitol is a plant-based sweetener. And what they found is it's antibacterial naturally. It's also sweet and it doesn't create it's not carcinogenic, doesn't promote decay. So it's not like fructose or glucose or any corn syrups or any sugars that we would normally see in our food products. They even sell it in a powder form if you want to add it to coffee. The magic that they try to follow with xylitol is to have 5 exposures per day. So you can have some with your coffee, you can have some with iced tea, you can have it with, there's some mints, there's gums, a wide range of products. It's also in certain toothpastes. My only caution with Xlear is they do have a product line that is fluoride free, and I don't like that. I would rather have the fluoride component added into the system. As I said before, fluoride's a big adjunct, and there's a lot of misinformation about it. I would also add, as a side note on this, that the key to fluoride is dose, and like anything, dose defines the poison. It doesn't matter what the product is or what the food is. If you have it in proper doses, perfectly safe, and having it in your toothpaste and having it in an oral rinse is perfectly sound. David, can I go to the next slide? So the other thing we have for management, as we talked about the chemical component, this is the fluoride. This is what I've already kind of covered. The closest we've discussed, the chlorhexidine, I've already mentioned the downside of it. I don't think it helps a lot with its intended use, which is gum issues, and it has that unsightly staining on it. And fluoride uses, again, in our office, we use a fluoride varnish, which has become prevalent throughout the whole industry. We used to use tray-based systems where you would bite in a tray for several minutes. The home caregivers sometimes have to help us with fluorides. We don't do home varnishes, but the irony with varnishes, they've been around for many years. I even remember 20 some years ago in dental school, we had Copolite fluoride varnish, but nobody used them for one kind of silly reason. It was brown, and nobody wanted to walk out of the dental office with brown teeth. The fluoride varnishes today are clear or have a slight white tint to them. And the varnishes, when they're applied in our office here, they're just painted on. It's really sticky, has a very limited systemic effect or no systemic effect. And we let it sit on there for about 4 hours. And when you brush your teeth, the residual components come off. Next slide, David, if I could. As I said, management is key, and it becomes more difficult. People are living longer and they're living with more complex lives. So I still believe that prevention is the best defense to having problems. And in days gone past, where we used to do heroic dentistry, where you're doing big convoluted restorations, I found that there's a poor prognosis for these folks and for these teeth as they age. And you end up with a lot of compromised teeth and a compromised dentition. If you imagine doing large fillings and large convoluted fillings, it's a complicated shoreline. If you have a circle, and I'm going to put my hands up, you have a circle with a shoreline like this, it's the circumference of that circle is pretty straight up. It's a very simple ability to calculate. Now, if you imagine inside the circle going convoluted in and out or wrapping around in different directions, you get a lot of shoreline. If you looked at the shoreline for the Great Lakes, there's more shoreline in the Great Lakes than there is on the East and West Coast combined. So that's why I reference shoreline concerns. And I find that a lot of the heroic dentistry is not a long-term solution, because all of these fancy margins we talked about before become under attack very quickly. Implants are amazing. They're artificial teeth. It's metal. They don't decay. They can keep dentition in the mouth so you can maintain nutrition, but it's also dependent on the medical status of the patient. Someone with a lot of medical complications becomes a very major barrier to having implant therapies. It's not the same as teeth. it's also not an overnight solution. You'll see advertisements on television and on the internet for things like Clear Choice and for All on X Teeth, and every implant company has their version of this, and they make it sound like you walk in, they put you to sleep, and you wake up, and then you go to Morton's and you're ready to eat. And what they don't tell you is the healing time, the complications, the invasiveness of the surgeries for this, particularly when it's all done overnight, and you're not eating anything tougher than a banana for a good 6 months. And that's something that I think implants, while it sounds great, might not always be an easy solution for larger situations. So if you're going to do implants, you're going to go into that world as a good therapy. You want to try to stage that. We're going to kind of come around on that here in a little bit. Next slide, David. So today and tomorrow, what's happening? Well, the focus, you have to do dentistry. You don't have an option. When you have to do it restoratively, the focus is to be minimally invasive. And I would try to avoid the heroics. Ways to stay minimally invasive, I use a lot of technology. So earlier on, I got into lasers, and as high magnification as I could use. The magnification lets you catch things sooner and earlier. The lasers can make some therapies less invasive, and a laser will allow me to modify a gum line and provide access for both decay removal, and it lets me keep the natural dentition a little bit better. It reduces that shoreline, as it were. With implants, we want to try to stage it, do sections at a time as much as possible. And I also would tell you that principally for patients with Parkinson's, cost can be lessened if you stage treatment. Guided surgeries become very important, and again, perhaps it's a bigger topic for a different day. But an implant surgery is not an implant surgery. Every doctor does it differently. Some doctors like to do it freehand. When I was placing freehand implants, one implant was a 90-minute process, which is a long time. But guided surgeries, where you can place an implant in a patient's mouth, today takes 6 to 9 minutes on the top end. That really improves the ability, and it opens up the implant world to patients with Parkinson's. The biggest problem as historically with implants has been cost barrier, which is right now we're using scanners, surgical guides, and we're also using faster systems for getting an implant in that are less invasive than the traditional models. Surgery can be a topic for another time, or if anybody wants to talk about that, I can go through that in more detail later. But again, with Parkinson's patients, I always recommend trying to stage these things rather than do them all in a day. Next slide, please. The other big thing here, where tomorrow is really happening today, it's now, and that's the age of CAD/CAM. And this is something else we've introduced into the office. I've had CAD/CAM in my office for a lot of years, but it hasn't been as effective as it's really been in about the past 3.5 to 4 years. And the most common system is called CIREC, and it's where you would prepare a tooth for an indirect restoration that's made outside the mouth, and then you make it while the patient waits. You're also seeing the advent of 3D printing. In the CAD/CAM world in particular, the technology and materials have been phenomenal. The quality of products that we have available to provide in-office treatment in one day, not just one day, but 1 hour or 2 hours to get a crown, inlays, onlays, is amazing. The work product right now, with the margin capability of the material we can mill actually in the office, is second to none. The laboratories have been doing this for years. It's just now coming into the offices. And the system's called CIREC. It's another adjunct is 3D printing. The 3D printing really comes into play for making partial dentures or temporary prostheses that are not the hard ceramics. biggest advantage is it's all one visit, and it's not a lot as much chair time. So even though you might be here for 2 hours, it's not as much chair time. It's easier on the patient. The material science is really advanced. The downside is the doctor's got to spend a lot of money. So I call that the bleeding edge of technology versus the cutting edge of technology. It's on the front end of that. I tend to be there because I'm a glutton for punishment. Um, but CAD CAM with lasers is amazing for saving teeth. And it lets you limit that shoreline, lets you get good margins on your restorations and good access to it for cleaning. The 3D printer world right now is coming into bear. It's not as common, but as I mentioned, removable dentures are done in roughly an hour of processing time in the printers. They still require some work. There's two principal companies out there, I think, that really dominate that market. One of the downsides is that doctors don't like is they can smell. It's a heavy chemical smell, but it works, and it's an incredible adjunct. It's the one piece of equipment I really don't have in my office. And David, if you can flip the slide for me. So what's in the future? Well, this is where it gets really fun. The current buzzword is artificial intelligence. You probably see this everywhere. Chatbot, Chat GT. There's a whole bunch of them out there right now. We're seeing it in dentistry and a lot of the media advertising to doctors, where the companies are saying, "Oh, we're using AI. We're using AI," and I don't really believe it's truly being used in the sense of what the school kids are doing for writing their school papers. But I do think that they're really using filters and software to really facilitate better imaging and to identify things at risk. It is in its infancy. It's not something that's really well developed yet. And a lot of the companies are really trying to capitalize and be the first ones out there with legitimate software for doing this. I think the biggest role for it has to do with our imaging and diagnostics. We're also starting to see it crop into management software where it will go into our softwares. It'll scan our patients and identify them for all kinds of different things. The biggest downside, there's no rules yet for who it's used. And I look at this as an issue with accountability, responsibility, and liability. With accountability, who's responsible for what it tells you is there? And we don't have an answer for that. Who's responsible for what we do with that knowledge and that data? And then who's going to have ultimate liability? Can a doctor come back and say, well, it told me this was going on and lean back on it? Especially when you're getting in the world of pathology. This is something I've become very active in just recently. A group of us are forming a volunteer board to create rules for the Commonwealth of Virginia, where I'm located, and the rules here don't exist. So we're trying to set it up so that the doctors know that it is just another tool, and that the doctor still has to maintain responsibility, and the doctor still has liability. We also want to be really careful with the use of insurance companies, because an insurance company can use this to deny claims, to modify treatment, to push the doctors into ways to avoid their own liability, underwriting responsibility, and the like. That actually scares me a lot more than anything, because that's going to be very prevalent, not just in dentistry, but in medication, or rather in the medical model as well. David, can you go to the next slide for me? And there we go. Last slide. As I mentioned before, in sum, Parkinson's complicates everything. It accelerates that aging process and it puts everything at risk. Oral management has to be multifocal. We have to manage it medically. We have to manage it mechanically and chemically. New technology is catching up to facilitate improvement, and it's becoming more widespread in use. The patients are the victors of that. One of the downsides is that you got to make sure the doctors are willing to invest in the money for that. And from my chair, it's going to be really fun to watch how artificial intelligence tries to make changes. I am very cautiously optimistic that we can get good rules, and I'm sure there's going to be growing pains as these new rules get implemented in their use, but it should be pretty fun. But that's what I think the future is. And if you asked me 2 years ago, I wouldn't have said that would have been the case. Is there any questions? Or if you would like, you can email me, or get the email, get the question to David, and I'm happy to take care of any questions you've got. How's that?
Well,
I think we
it's-
did have a couple of comments in the
Sure.
chat, but I can't seem to.
I know I saw one comment, someone asked where I am. I'm in Northern Virginia in an area called Sterling.
Yeah, there are a couple of comments here. I've had a lot of dental work this past year. Every one of the dentists and specialist dental care professionals use x-rays and various scanning equipment. Are there any concerns these days about radiation buildup? I think I've had about 20 of them this year of various sorts.
So you're probably okay. Our levels in the dental office are so low. Matter of fact, I've heard a reference that our bite wing x-rays right now are equivalent to eating a banana or having an avocado. So same levels of radiation. What's happened with the technology that's come in, and I'm glad you mentioned that because I didn't have anything on this in the presentation, but imaging technology has really improved. So, and with the imaging technology, we have lower levels of radiation and higher data collection than we could have dreamed about 15, 20 years ago. My cone beam CAT scan is less than 1% of a hospital CT. And it's unbelievable amount of data. That always cracks me up. Somebody doesn't want my x-rays, yet they'll let the hospital take a routine chest x-ray. And I go, there's no such thing as a routine chest x-ray.
Someone else also posted in the chat, I recently had dental work done and discovered that lidocaine caused my blood pressure to drop dangerously. Is this common with Parkinson's patients?
I think it's more of an aging issue. If you give a lidocaine injection, it's usually the epinephrine, the adrenaline component. If you could get it in your overall system, that's an effect that can happen. And it's with any injection. It wouldn't just be focused on lidocaine itself, but any dental injection. The key thing would be, one, try to limit the amount of epinephrine in it, switch to if need be, something like a mepivacaine, where you'll sometimes hear the term carbocaine, which doesn't have any epinephrine in it, might be a solution to talk about with your doctor.
I don't
And
see
Nan-
anything else in the chat.
Nancy, I've got one.
Okay.
If you have many crowns and a few implants, do you still need fluoride?
I would, if you have one natural tooth, I would get fluoride.
Thank you. Another question just popped up, Nancy and
I
Dr.
saw a drooling comment there.
Oh,
Yeah,
yeah.
that's it.
That's a lip competency issue with that. Yeah, the $1 million question is it, even though you have a drooling, that's really a lip competency concern, and being able to maintain normal saliva in the mouth, I would still be very cautious with salivary flow and making sure that everything is clean. And you might also have a decreased quality of saliva for protecting the dentition from decay.
I have a question.
Yep.
I know you talked a little bit about the xylitol products. Xylitol gets a lot of very interesting press in its use as an artificial sweetener, and it has been demonstrated to have, in some cases, a GI impact because
Right, and
xylitol is used in
it's same with Splenda and the like.
yeah.
The comment would be that xylitol, if you can tolerate it, is not half bad. I personally find that it also has an aftertaste that some people find unpleasant. But yeah, you got to watch out with the GI impact. It's a bigger impact with the Splenda, which is the sucralose product, but with any of them, stevia as well. And stevia is a nice product, but it doesn't really have anything in it. And it's hard to get pure stevia. You have to get a liquid form usually. And most of the powdered stevia products are actually a combination product. And the Splenda, sucralose, and stevia products are not as effective like xylitol for being anti-cariogenic.
I was gonna ask if anybody wants to raise their hand. We can, if you have a question that you cannot type in the chat, just use the raise hand feature.
John has a question. But John, you have to unmute yourself.
There we go, John. I just asked you.
Okay.
Go ahead.
Can you hear me now?
We got
Yes.
you.
Okay. I'm curious to know how much dental care is related to impulse control with Parkinson's patients. I have taken in a lot of sugar. I've been really technically addicted to sugar for many years. I've had Parkinson's for many years. I don't know if it's a substitute for pleasure that you get, but whatever it is, it's caused terrible problems, and I've had a lot of work done this year. The good side of it, if there is any good side to this, is that because I have so few teeth left now, I'm getting a lot of work done. I've lost a lot of weight because I can't really enjoy eating, but
One of the big components to help you with that, the implant world can be very helpful, especially if you can stage it to get through the surgeries. The downside is it's a lot of money. It can be very expensive,
it's going to cost.
it's going to cost. I know in my office, what we do for this, we will tend to flat fee it and break it down, flat fee the systems so that there's no hidden surprises mid-treatment. But you do it over a little bit of time. And the implant options are pretty effective out there. I will also tell you, not all implants are created equal. They're a bit of a commodity in the industry. I speak for one company a lot because I think that they've got the best solution available. And I can go through your specific issues with it, but yeah, the sugar control, that's welcome to the American model right now. And it's a source of everything from obesity to dietary concerns. And it's a huge component of almost every single illness. And I mean, I've struggled with it myself. I got into dentistry because I got a terrible sweet tooth.
Dr. Jackomis, I have a question from a care partner perspective.
Yep.
So in situations, there might be times where a person with Parkinson's may have the dyskinesia, the involuntary movement. And as a care partner, may have to come in and have some dental work done. Do you recommend like reducing the amount of medication before to help prevent the dyskinesia, or how do you handle dyskinesia?
I would personally, I get really nervous when I'm messing with somebody's medications. I try to stay away from that. I try to not mess with it. I just try to work around it.
Okay.
And when you're bringing anything to the mouth, you have to be very careful if they're having that uncontrolled movement. Make sure you're riding with them. You got to go with them, and anything sharp, dangerous. That's what we're dealing with that every time we go in the mouth. Nobody wants to come here because we got all the sharp things. But you got to be very careful, and don't try to restrict them. Don't try to restrict that movement. Try to go with it when you're trying to help them out.
Thank you. We got another question that just popped up in the chat. Says, my bottom teeth are becoming crooked. I noticed that I'm sleeping with my mouth open with a lot of drool. Are the two related? I'm trying.
They're probably not related, but they're probably signs of time. Signs of time. Teeth will naturally drift toward the midline, usually. And open mouth, it could be anything from even apnea. Would be something to kind of consider as well, in addition to everything else. Airway issues and sinus.
Yeah, they say they're trying mouth tape to force the breathing through the nose.
Yeah, good luck with that. I think that's the idea of taping your mouth shut to me. I'm more of a passive interventionist on this stuff. I would probably get a sleep study to see if there's apnea and consider a CPAP, because with the positive pressure, you can't have an open mouth. It forces it closed. And if you guys have anything too, even if you think of anything, feel free to email me with any questions you've got. I will answer anything I get, whatever you can think of, and it doesn't have to just be today. The board members here they know how to find me very easily, and easy questions. And if you want me to talk to someone, if you want to call me, talk with me, you're absolutely welcome to do so. It doesn't matter where you are or what you need, whatever I can help with, I will. But I want to thank you guys for having me out here today to talk. And like I said, with me, it's always an open door for whatever I can help with. And I'm going to have to let you guys go. They're banging on my door here. We're running a little bit long on my end. But make sure that if you need the presentation, David has everything. Any questions, please do not hesitate to reach out and let me know what I can help you with if I could.
Thank you so much for your time.
Thank you very much.
Thank you so much, Dr. Jackomis.
Have an amazing day.
You too. Take care of yourself.
Bye.